Let's carry on with gastrointestinal system drugs. We're going to talk a fair bit about emetics, and when we have emetics, we're talking about two categories. We have centrally acting, which stimulate the chemoreceptor trigger zone and the emetic center, and then we have locally acting, which actually irritate the lining of the stomach or some part of the gastrointestinal system to create emesis. Centrally acting emetics, first off, we'll talk about apomorphine. Apomorphine is an opioid narcotic, so that means that it was derived at some point through synthesized derivatives of poppy seeds, so it comes down the line essentially at one point being related to morphine. So of course, if we're using an opioid narcotic such as apomorphine, we have to ensure that we write it down in the controlled drug log, so it is a controlled substance. This is most often used for dogs, and it's the #1 emetic agent in dogs. So apomorphine works to stimulate dopamine receptors. And what does this mean? Well, dopamine stimulants, so when dopamine is stimulated, it causes emesis. And then, of course, from last lecture, what do you remember when it comes to cat and dog dopamine differences? Well, looking back, the drug sensitivity varies dependent on the species, so we're talking about a different number of receptors in that chemoreceptor trigger zone. So dogs, we have an increased dopamine receptor, so an increased number of dopamine receptors compared to cats. So when we stimulate those dopamine receptors, we get more successful emesis. Whereas opposed to cats, they have decreased dopamine receptors, which essentially means that if we're relying on stimulating the dopamine receptors for emesis, it will be less effective in cats because they have less of those receptors overall. So of course the key point here is that dogs and cats respond differently to emetic and anti-emetic drugs based on the number of these receptors. So of course when we're talking about apomorphine, cats have less dopamine receptors, so they are less likely to actually vomit when given apomorphine. Dogs have more dopamine receptors, so they're more likely to vomit when given apomorphine. As mentioned previously, it's also an opioid. Opioids have specific features affecting the body. They cause depression, or they suppress the central nervous system function. So of course, side effects of that, they can cause a bit of sedation. We can get a little bit of a decrease in cardiac and respiratory output. And we get suppression of the emetic center in the medulla of the brain. Whoa, what does this mean? Because now that's going back. We're trying to create emesis, and then here I am telling you that we're actually suppressing it as well. So that leaves a lot of questions. So when we're looking at apomorphine, it causes emesis, but it could suppress emesis. So it's all about which zone is reached faster. So if it reaches the chemoreceptor trigger zone first, then we get emesis. If it reaches the medulla and the emetic center within the brain first, then it's actually going to suppress emesis. So an example, intravenously, it will be detected in the blood by the chemoreceptor trigger zone, and emesis will start immediately. Whereas later on down the line, as it gets distributed throughout the body, then it will work its way through the blood-brain barrier and reach the emetic center in the brain, and it will be suppressed, which is kind of good because it means that apomorphine, the emesis effect of apomorphine doesn't last forever. Once it reaches the chemoreceptor trigger zone, it causes emesis, but then after that, once it works its way through the blood-brain barrier, the emesis should wear off because that opioid factor is going to suppress the emetic center. If the opioid properties reach the emetic center in the medulla first, it will shut down and prevent emesis. So that's something to keep in mind. It's all about which is faster. So of course, when we talk about the factors that affect absorption that we talked about previously, a lot of it is about the route of administration. So in this case, it's definitely about the route of administration. So typically we're talking about intravenously or transmucosal is best to win the race to that chemoreceptor trigger zone. So intravenously, you all know what that is. When we're talking about transmucosal, what we're often doing is applying a highly dissolvable tablet into the conjunctival sac, so that space between the conjunctiva and the eyeball, just placing it in there and allowing it to dissolve, and then it gets easily absorbed through the mucous membranes. Benefit of this is you're not wrestling a dog to give it an intravenous injection, but at the same time, I do find it causes local irritation, and then you have to fish out that tablet after the fact. So it's irritating to the conjunctiva, the actual tissue, and it can be irritating to the sclera of the eye as well. And then afterward, if you have a dog who has an irritated eye, now you have to get a moistened Q-tip or a cotton-tipped applicator and try to fish it out. So it's a little bit challenging in that way. So again, because it's an opioid, one nice thing about our opioids is that they can be reversed to a degree, and I have reversed in quotations, because what we're doing is, in fact, we're going to replace the receptor take-up with an antagonist drug instead of an agonist. So we can give an opioid antagonist, such as naloxone, and that will actually reverse the central nervous system effects. It will not reverse the emesis. Okay, so if the dog is quite sedate after giving apomorphine, sometimes puppies get quite sedate, it hits them pretty hard, then we could, if we're concerned about the cardiac or respiratory suppression, we could actually administer an antagonist, an opioid antagonist, to reverse those effects. If there's too much emesis, so if they are just throwing up and they're not stopping, we can reverse with a dopaminergic antagonist. So we can use an agent that, again, will just take up space on those dopamine receptors without causing an effect. So in that case, if the vomiting is quite significant, we could give acepromazine, which is a phenothiazine tranquilizer, which we'll talk about a little bit later. Oftentimes, too, we tend to give a drug like Serotonin, which is another agent that stops emesis. So we'll talk about the options. Most often I find we're not giving the dopaminergic antagonist. Normally we just let them ride it out, or we'll give them a little bit of metoclopramide to help things move down through peristalsis or Serotonin. So then what about cats? Because we know that apomorphine is not going to be overly effective in cats, or we can't guarantee its outcome in cats. So cats, we tend to rely on an alpha-2 agonist drug, such as xylazine or medetomidine or dexmedetomidine. So this is dexdomitor, which is the trade name, and dexmedetomidine hydrochloride is the generic name. These are sedative anesthetics, and they stimulate the alpha receptors in the chemoreceptor trigger zone and in the emetic center. So with these, we get more predictable vomiting within minutes of administration in the cat. Dogs less so, but cat, it's the number one most reliable way to induce emesis. So alpha-2 agonist drugs, another benefit is that they are reversible as well, so they're entirely reversible, because of course if we're giving a sedative to cause emesis, we have to expect that sedative effect within about 15 minutes as well. So we don't necessarily want the animal to have sedation or severe sedative effect for very long. So we can often administer the alpha-2 agonist, and then we can reverse it with an alpha-2 antagonist, such as adipamazole, which we use for medetomidine and dexmedetomidine, or yohimbine, I spelled that wrong, I see, which is a reversal for xylazine. So this is the best option. It's the most reliable emetic agent in cats. It's not overly reliable to produce emesis in dogs. And the dose, when we're using it, because again it is a sedative, the dose that we're typically going to use is less than the regular sedation dose, so that we don't get the animal, so that the animal's not overcome with sedation before they're done vomiting. And then we have locally acting emetics, such as hydrogen peroxide. This is one that some clinics will recommend at home if the client calls to say, my dog just ate chocolate like 10 minutes ago, a ton of chocolate, what can I do at home? So these ones are gastric irritants, and typically hydrogen peroxide is what we're recommending, if anything. The challenge with it, because it is a gastric irritant, it can cause significant gastritis. So hydrogen peroxide is a possible option for dogs, not so much in cats. So for dogs, but they have to be in really good health, and we have to be cautious of using it alongside of other medications that could otherwise cause things such as gastric ulcers, because it is a gastric irritant. So 45 milliliters is the absolute max that any dog should get. And of course, 1 to 2 mils per kilo is typically the recommendation. So quite often what we say is give them some food so that they've got something to actually vomit up and to bulk up whatever they are going to bring up. and then administer their 1 to 2 mils per kilo. If no vomiting after 15 minutes, you can repeat it once. When speaking to a client, you have to remember that it's important to tell them it has to be fresh, so it has to be a new bottle of hydrogen peroxide, has to be bubbly, and of course caution with aspiration because this will lyse the cells within the pulmonary tract, so we don't want them aspirating because of course it can be an irritant to the respiratory tract as well. We also have one called syrup of ipecac, which is over the counter, you can get at drugstores. It's a gastrointestinal irritant. It contains an alkaloid agent that's toxic to heart, liver, and kidneys, and high concentrations are cardiotoxic. So typically we don't recommend syrup of ipecac so much anymore. Salt's another one. Some people ask, can I just dump a teaspoon of salt down their throat and hopefully they'll vomit? This one is very variable. There's so many variables with this one. I find salt doesn't work overly well for animals, so when clients ask you that, it's just not recommended. It does stimulate the pharyngeal receptors for emesis. The unfortunate part is, of course, if it's a small dog and they're giving a teaspoon to a tablespoon of salt, then we can get salt toxicosis if they end up just swallowing it and leaving it in their stomach. So, of course, salt toxicosis, we can get tremors, seizures, hypernatremic death. If the owner does give it at home, you have to remember that they should also be offering water or ensuring in some way that that animal gets water, not forcing it down their throats. And then IV fluids is ideal to reduce the risk. So salt in high quantities is not good for the body because, of course, we get that exchange for sodium and potassium and we can disrupt the electrolyte balance. Mustard, some people recommend mustard. These are things that just your clients will call you about. So some clients ask if they can give mustard. Not ideal. The seeds themselves are toxic and it's a significant gastric irritant. And then of course, if we get it in the eye or if they aspirate it, it's going to be a significant tissue irritant. And then some people just ask if they can shove their finger down their animal's throat. It's not overly reliable, and most often the client ends up getting into more trouble than the pet because they get their finger bitten. So we don't recommend any of these, just as an FYI, in case your clients call you. So of course, we have to have some thoughts on induction of emesis. So what needs to be considered before induction of emesis? And we get a client that calls, my Yorkie just ate a pound of baker's chocolate. That's crazy. That's a lot of theobromine. I live around the corner from the clinic. What should I do? So what's your advice and why? Why would you choose that advice? So what, of course, in that case, if they live right around the corner from you, the best advice, if they just ate the chocolate, they live right around the corner, just come in. Just come right in. We know that we can administer apomorphine intravenously, get that dog to vomit, and we're not going to play around with the dog. We're not going to play around with all the different variables involved in hydrogen peroxide or sticking the finger down the throat or anything like that. So realistically, just come in. ASAP is the best advice that you can give. What if we missed our time window for emesis? So we know that within a couple of hours at most is the best ideal timeline. Typically within the hour is ideal. Or what if the emesis is too risky? So if we have a corrosive agent, dilution. So water plus or minus gastric lavage. So if they've eaten something that would be corrosive when it comes back up, then of course we're not going to recommend induction of emesis. And instead, we're going to encourage that animal to physically get some water, whether that's in the form of canned food or actual water, into their stomach to help dilute that corrosive agent in their stomach. And then they likely should come into the clinic. Sometimes they need gastric lavage, so a tube going into their stomach, sucking out stomach contents, and then replacing it to rinse it through with water or saline. Not so much saline, with water typically. So sometimes they need gastric lavage to sort of empty out that stomach contents through a tube, which is in a safe manner. And quite often they'll need IV fluids and close monitoring for things like gastric ulcers. Toxin absorption. So if it's something that they've eaten that when absorbed systemically will cause a toxic reaction, such as rat poison, then quite often we're going to give activated charcoal. So ideally, if they're within the window, we'll get them to vomit, get rid of all the bulk amount of that poison that they've ingested. And then we're going to administer activated charcoal, which will help absorb some of that toxin. And then we have options for with or without sorbitol. Sorbitol we'll talk about a little bit later in the next lecture because we add sorbitol or we'll give sorbitol typically in the first dose to help move things through the gut. So help increase peristalsis to help sort of purge in the other end of the GI tract. Now we don't want to give activated charcoal with xylitol, with petroleum, and with alcohol. It does not mix very well and it doesn't do the job that we need it to do in its absorptive capabilities. And then of course if they eat something as well, that it's a bit of a wait and see. So let's say they ate a toy, the owner doesn't think it will pass. There's not much that we can do in that period between availability of emesis. So within that first hour, we could make them vomit. But after that, it's kind of a wait and see to see if it gets stuck in their gastrointestinal tract. So quite often, if it's something metallic, we can bring them in and get an x-ray done. But if it's something like a funky toy or a piece of foam, something that won't show up on an x-ray, then we often recommend giving frequent meals, so bread, canned food, etc., to help bulk it up and sort of help it slip and slide down through the gastrointestinal tract. All right, then we have anti-emetics. So when to use, of course, when do we use an antiemetic, and what are the cautions around the use of antiemetics? So the goal of an antiemetic is to stop or decrease vomiting. So you have to remember that vomiting is a protective mechanism and only use antiemetics when vomiting becomes a deterrent to the patient's health and recovery. So we don't want to give an antiemetic just to mask the signs of disease or the signs of improvement. And if there's toxin ingestion, it may actually, if we give an antiemetic, it may allow that toxin to remain in the gastrointestinal tract for a longer period of time, which is not ideal. So you have to be cautious about administration of antiemetics. So this is typically a doctor decision that we will then put through into action. But in general, history is so important for each patient before an antiemetic is administered. So the types of antiemetics, we've got phenothiazine tranquilizers, antihistamines, pro-motility drugs, serotonin antagonists, and NK1 receptor antagonists, and we'll go through them. So looking at phenothiazine tranquilizers, most often we're talking about acepromazine, which is also known as Atrovent, and chlorpromazine, which is known as Torazine. And the modes of action is that they block dopamine receptors in the chemoreceptor trigger zone and the emetic center. They have an antihistamine effect, so they block that H1 receptor as well. And there's a mild blockage of acetylcholine. So remember that histamine and acetylcholine have receptors in the gastrointestinal system, so typically within the stomach walls. And when they're stimulated, it causes an increased production in fluid and secretions and in acidity. So ideally, we're going to block these to help reduce the chances of vomiting through the reduction in production of gastric juices. Phenothiazine tranquilizers, typically clinical use is to prevent motion sickness, and it can be given, so we use acepromazine a lot in clinic. We use it as a pre-med, as part of a cocktail for pre-medication before surgery and anesthesia. And we also use it sometimes just to sedate the animal if they're a little bit aggressive or typically aggressive before they come into the clinic. But we also can use it to prevent motion sickness. So we're going to give it 60 minutes prior to travel with an empty stomach in the oral form. And the goal here is to reduce vomiting associated with severe enteritis. So essentially reduce the vomiting that's associated with stress gut, so with disruption to the gut because of the level of stress. Likewise, it's actually blocking the receptors to help reduce that motility, reduce the secretions within the gastrointestinal system. Side effects, we can get a decrease in blood pressure because we're blocking the alpha receptors. And we can get excessive sedation and ataxia. So they can look sedated, they can look drunk, they can have trouble walking, which can be a little bit challenging. Contraindication if we have hypotensive animals, so any animal that routinely has low blood pressure, we would definitely not give a phenothiazine tranquilizer. And we also have caution when using it in boxers. In boxers, phenothiazine tranquilizers, so acepromazine most often, has been shown to lower or reduce the seizure threshold. So in boxers, we worry that if they're prone to having seizures, and maybe we don't know that, then we can actually lower the threshold for seizures, and they'd be more likely to have a seizure if we give them phenothiazine tranquilizers. So that's a concern. Now the other thing, and you guys I'm sure we'll talk about this later on in pharmacology next year, when we're using phenothiazine tranquilizers, again, we're often using them to prevent the motion sickness, and they do cause a little bit of sedation, but have to be very cautious, because if that animal is a highly stressed animal in the car and they have a lot of fear and anxiety about the car, and that's what's causing their increased vomiting or diarrhea or that stress gut, we have to just remember that phenothiazine tranquilizers won't reduce the amount of anxiety or fear. So they will a tiny, tiny bit, but they won't have a huge role in impacting or reducing the level of anxiety or fear. So we just have to keep that in mind to maintain a well-rounded treatment for that animal. Because again, if they're just sedated, but they're just so scared still, it's not really fair to them, because instead we're just suppressing their ability to express it. So just something to keep in mind. And then we have antihistamines. So we know that histamine receptors are in the gastrointestinal system, and especially within the stomach, when they are stimulated, they cause an increase in gastric secretions and an increase in gastric motility. So we can use antihistamines to help block those receptors from being stimulated and help reduce the chances of that increase in secretions and motility. The antihistamines that you'd be most used to seeing are diphenhydramine, which is Benadryl in the trade name, and dimenhydrinate, which is Gravol in the trade name. And that Gravol technically should be capitalized because it is a trade name. Mode of action, so they decrease the vestibular apparatus impulse to emetic center by blocking the histamine receptors in the chemoreceptor trigger zone. Whew, that's a wordy sentence. So essentially they are helping to disrupt the signals from the ear that send signals to the brain regarding balance and disorientation. So through that route, they're also sending signals to the chemoreceptor trigger zone to tell it, hey, things aren't going well, I'm not very well balanced, I need to throw up. So we're disrupting that mode of action through blocking the histamine receptors in the chemoreceptor trigger zone. So it's kind of this cascade of events. One thing to remember is that dogs have more histamine or H1 receptors overall, so dogs tend to do better with these drugs. So dogs tend to have more of an effect when given Gravol or Benadryl for the purpose of reducing emesis, much more so than cats. Clinical uses, we're typically talking about minimizing motion sickness, some benefit in dog, poor response in cats. And of course, it has poor efficacy for patients with gastroenteritis. So it won't turn off the other cascade of effects that are involved in gastroenteritis. It's one thing to keep in mind. It's very specific to motion sickness. Side effects, we often get sedation, and contraindications, if there's any allergy testing going on in any recent amount of time, then we have to watch out because we're going to suppress allergic reactions by giving these medications. So if the dog's going to the vets to get allergy tested to finally find out what the heck it's allergic to, it's not a good idea to give it Gravol or Benadryl prior to the car ride. Also, too, some animals are reported to have opposite effects of this in regard to sedation. Some animals, same with some people, but some animals tend to go the other spectrum of things and tend to get hyperactive with these drugs. So that's something just to keep in mind. Then we have prokinetic drugs, such as metoclopramide. It's centrally acting, and it also has a local effect, a locally acting effect as well. So it blocks dopamine and serotonin receptors, which both when stimulated cause emesis, and it's often used as an antiemetic for chemotherapy patients. What does this mean for dogs compared to cats? It's likely going to have a better effect on dogs because of the amount of receptors that dogs have compared to cats. Prokinetic, it is prokinetic, metoclopramide as well, so the locally acting portion will increase the gastrointestinal motility, and it increases gastric motility without increasing secretions, which is really helpful when we're talking about moving things through. So I always think about metoclopramide. The goal here is to move things through, so increase peristalsis, increase gastrointestinal motility without causing more acid, because the acid is what's going to encourage emesis. So metoclopramide, Here we go. Precautions with use of metoclopramide. In normal doses, it's typically fine, but in high doses or repeated doses, it can cause sedation. And we're going to avoid with the use of phenothiazine tranquilizers. So if the animal's had acepromazine, at the same time, we don't want to be giving metoclopramide. As part of an overall broad spectrum treatment plan, they could be used together, but not at the same time specifically, because you can get an increase in that sedative effect. Sometimes cats can demonstrate a frenzied behavior with metoclopramide because, again, we're not hitting the same receptors. We're not having the same effect on the receptors as we do with dogs. So we do use metoclopramide in cats, but it's typically a little bit less effective. And then one thing to be concerned about is this potential for frenzied behavior. And in patients who have a gastrointestinal foreign body and they're obstructed, so they actually have something that's blocking their small or large intestine, then there generally is caution in using this because it is a prokinetic drug. So the goal of metoclopramide is to carry on with peristalsis, push things through, get things moving, to take that material from the stomach out into the rectum, out into the open world. So if they are obstructed, we worry about this because it will increase peristalsis around that obstruction in their gastrointestinal tract. And of course, if it's something like a linear foreign body, like a piece of string, what will end up happening is we could just cause many micro lacerations with that string being pulled through peristalsis, and it just cuts up the lumen of the intestine. So those are just things to think about when using metoclopramide. Another prokinetic drug is cisapride, and it's a locally acting prokinetic agent. It does block serotonin, but not dopamine receptors, and it increases smooth muscle tone. So it increases the likelihood that that smooth muscle will in fact be able to contract. Cisapride is one that you'll see regularly used in cats with chronic constipation issues, especially when it comes to megacolon. So if they have a huge, enlarged, floppy colon that doesn't have a lot of muscle tone and the animal's having a hard time having a bowel movement, then quite often we can use cisapride for this specifically. And because, again, it does block the serotonin but not the dopamine, we're not fully relying on the blocking of dopamine receptors. So of course it would be a little bit more beneficial in cats for that way. In constipated cats, cisapride is almost always part of the protocol. And the main thing is just it's like an exercise for their colon. Okay, so it's bulking up the muscle tone in their colon to help be able to undergo peristaltic waves and push that bowel movement out. So I like to think of it as colon CrossFit for constipated cats. Cisapride, like metoclopramide, can cause sedation in high doses and repeated use. Again, we're going to avoid with phenothiazine tranquilizers to avoid that added sedative effect. Sometimes cats can demonstrate a frenzied behavior as well, so that's something to keep in mind. Same idea with metoclopramide in regard to obstructed patients. We are increasing the smooth muscle tone and increasing the peristaltic waves, so you have to be cautious if they have something actually stuck in there, especially when it comes to a linear foreign body. It's cardiotoxic in humans, so this is something that if you look up cisapride, you'll find a lot about cardiotoxicity, so heart toxic. Has not been proven in animals. So just something to keep in mind. Who knows, in years to come, maybe there will be studies that prove it in animals, but currently it's not proven in animals. And caution when using opioids with any prokinetic, because opioids actually will negate the anti-emetic properties of prokinetics. So that's something to think about. Opioids trigger their own emesis effect. So essentially when we're giving prokinetics to avoid emesis, again, depends how fast those opioids reach which part of the body, but they can potentially negate that anti-emetic property of the prokinetics. And then we have serotonin antagonists, ondansetron. So ondansetron it essentially blocks serotonin receptors in the chemoreceptor trigger zone. And serotonin is involved in emetic center stimulation from peripheral nerve transmission from the GI tract. So essentially by blocking those receptors, of course, we're going to block the chances of emesis. And it's also an anti-secretory or secretory gastrointestinal drug. So it's going to reduce the amount of hydrochloric acid secretions through the gastrointestinal tract and through the stomach specifically. And then it's also going to utilize those serotonin receptors, block them, to help prevent emesis. Ondansetron is definitely used in human medicine. I've seen it used in post-chemo patients. So anytime a person has chemo, one of the drugs within their therapeutic protocol is often ondansetron. So clinical uses, we're using it typically on top of other medications for breakthrough vomiting. So when vomiting has seemed to go away for a while and then spontaneously recurs. We often use it in parvovirus patients, so animals that have that attack on their gastrointestinal system by the parvovirus. They have constant vomiting and diarrhea. We'll give ondansetron in those cases, and as a post-chemotherapy drug as well to help combat some of that nausea. We have to have caution because it does play on that MDR1 mutation, so that's that white feet don't treat mutation, where collies typically have less of the P-glycoprotein availability to them. So remember that the P-glycoprotein helps break down some drugs in the liver, and then of course some drugs rely on the fact that P-glycoprotein will break them down, so the dosage is relying on the fact that some of the drug will be broken down before it's fully metabolized and absorbed and distributed into the tissues. So dogs that have less or potential to have less P-glycoprotein could actually get higher doses of the ondansetron because of that. So it goes directly into systemic circulation rather than being broken down. Also, hepatic dysfunction, so patients that don't have a well-working liver. Ondansetron definitely undergoes that first pass effect. And in humans, so again, this is the fact that the drug dosaging is relying on the fact that some of the drug will be destroyed in the liver before it goes into systemic circulation. In humans, liver insufficiency has resulted in toxic levels. So we don't necessarily have a lot of papers that adapt that to animal use, but it is a caution as of right now. If the animal is in liver failure or has severe liver disease, then a little bit of extra caution with ondansetron, because if they aren't able to send it through the liver to go through that first pass effect, they're going to get a higher dose than what their body needs. All right, and then we have these beauties. NK1 antagonists. So meropitant citrate is Cerenia. And Cerenia for us in the veterinary world has been a game changer in the last few years. So it is an amazing anti-emetic. The mode of action is a bit tricky. It blocks substance P from binding with neuro-1 kinin receptors in the emetic center. So essentially what it's saying is it prevents this combination of these two substances from combining, that essentially when they combine, they create this cascade effect of emesis. So when they combine, we get a lot of emesis from that. So in this case, it's just preventing that binding of those two agents in the emetic center. The interesting thing about Cerenia is that it's also responsible for blocking pain. So one thing that they're finding, they've just put this on label for use in cats as well, to a degree, but it's been on label for dogs for quite some time. What they're finding, though, is a lot of cases we're going to start to use Cerenia quite often as an adjunct pain management therapy. So in addition to opioids, in addition to non-steroidal anti-inflammatories, things like that, we actually start to see Cerenia being added to that protocol to help with pain. So then those NK1 receptors, they are the last step in the emetic cascade, so that whole process that ends up causing emesis. And the chemoreceptor trigger zone, the vestibular apparatus, the peripheral nerve input, and the GI tract, they're all affected by that NK1 receptors. So that all of those come together, and then of course that last step is that combination of the NK1. So again, we're blocking that combination to help prevent that last step to create emesis. And also too, really important about Cerenia is it can have some anxiolytic properties as well. So it's an interesting drug to keep your eye on. Right now it's on label as an antiemetic. I suspect in the years to come it will become on label as well for pain management, and then possibly as well for anxiolytic. So one thing that's nice about it is if you're using it for those dogs or cats that have challenges with car rides and they get car sick, if they do have an anxiety component to their car sickness, then this can have an additive effect. So it can have a beneficial effect in those circumstances. Administration's a little bit tricky. So the oral tablets is very specific. You have to feed a small meal 2 hours before travel and give dose 2 hours before travel. Okay, so give the dose. So typically give a little bit of a food, meal, just a small meal, 2 hours before travel, and as soon as they're done their meal, give their little Serenity tablet, and then absolutely no food for the 2 hours prior to travel. Okay, it is best with food in that case. If we're giving it subcutaneously, it's on label for subcutaneous use as well. We want to refrigerate to reduce the injection sting. So this is one that you often have to give naughty puppies who have been vomiting, they got into something. We're going to give them Serenia. It's once a day, so it's every 24 hours. And we're going to give them some Serenia injectable to help see how they do, see if they'll stop vomiting. This stings like a crazy son of a gun. It's crazy. So we do give it IV, sub-Q it's on label for. So we give it IV, sub-Q, they both sting. So if we're giving it IV, try not to slam it in too fast because they're going to feel it and they will go to bite you. It's very painful. And subcutaneously as well, really, really important is have that animal restrained really well because it does sting like a son of a gun. It only lasts about 30 seconds and then they tend to be okay, but it's just something to keep in mind you need to be prepared for is that it does sting. Intravenously, when we give it, like I said, just don't bolus it. Go slow over 1 to 2 minutes to help prevent that sting. So meropenem clinical uses, acute vomiting, so typically parvo, gastroenteritis, pancreatitis, motion sickness, post-chemotherapy, and also with vestibular disease. It works against central and peripheral causes of vomiting, which is great, so it's multi-action. Caution, if we have a gastrointestinal obstruction, we don't want to be just masking the clinical signs, right? So if they have an obstruction and they're persistently vomiting, then we need to investigate further. So that animal needs to have x-rays done to identify if there's any sort of blockage. If there's a toxin ingestion, just keep in mind too, if we should allow for that to come out if we give an antiemetic. It can actually be in contact with the gastrointestinal mucosa for longer and more of it could get absorbed. Bradycardia and cardiac patients in general, just be cautious. It could potentially play with the sodium and potassium channels, so it could have an impact on cardiac patients. So we would just try to not pair it with a severe cardiac patient. And it is a highly protein-bound drug as well. Okay, so we're going to move on, and this is my favorite comic of all time, theawkwardyeti.com. If you guys want to look it up, it's pretty fabulous. We're going to look at diarrhea. So diarrhea overall, the physiology, and we'll go through the types of anti-diarrheals. So diarrhea is really, stool consistency is a balance between the secretion of fluid from the body into the intestinal lumen, so into the intestine, essentially, versus balancing fluid absorption from the intestinal lumen into the body. Causes, we have many causes of diarrhea. We have secretory, which is bacterial exotoxins or inflammation causing increased intestinal cell secretion. We have exudative, which is inflammation caused by prostaglandins and leukotrienes and damage to the intestinal tract. So it could be an ulcer or parvo, but they essentially cause leakage of electrolytes, plasma proteins, or even blood itself. And then we have motility, which is rapid movements of intestinal contents. So the small bowel could be watery or could be explosive. And then if it's based in the colon or the large bowel, then we're going to get frequent small stools and straining. And then, of course, we've got osmotic or malabsorptive diarrhea, which we're getting undigested food, laxatives, and, of course, fiber holds water in gastrointestinal tract. So one thing that we'll talk about next lecture is exocrine pancreatic insufficiency, whereby the food is not getting digested appropriately and it just gets shot out of the intestinal system instead of going through absorption. So intestinal motility, we have two types of contractions. We have peristaltic and we have segmental. Peristaltic, we're talking about essentially a stricture or of muscle working its way behind the food bolus to push it forward. And then segmentation, we have continuous paired movements, contractions at the same time to help with bulk movements. So decreased segmental contractions or increased peristalsis causes more rapid transit time. Antidiarrheal drugs, we have opioid derivatives, we have anticholinergics, anti-inflammatories, absorbents, and protectants. So opioid derivatives, again, it's kind of funny to think that we use opioid derivatives for so many of these gastrointestinal issues, but we have essentially loperamine, which is Imodium. This is an over-the-counter opioid derivative. It's has significantly less opioid concentration, so it is not a controlled drug. Okay, loperamine is not a controlled drug, so we don't have to record that. And of course, we know this because it's over the counter. Diphenoxylate, or Lomotil, is a controlled class 5 drug, so it's low on that class system, but it is a controlled drug. For both of these, the mode of action is increased segmental contractions. So that segmental contraction will it's like the stop sign. So when it's contracting, it stops the flow of bowel movement so that it can help firm it up, typically in the colon. And it's also going to decrease peristaltic contractions. And peristaltic are the ones that are really pushing things through. It could have possible anti-secretory effects on the GI tract cells as well. So the adverse effects is, unfortunately, in some patients, and of course this is often dose dependent and frequency dependent, but we can get ileus and constipation. So ileus is an overall stoppage of movement within the gastrointestinal system, which of course in itself can cause a lot of issues because we start to lose blood supply and function over time. In high doses, it could cause sedation and even lethargy. And there is potential central nervous system excitement, typically in cats. So we often avoid these in cats, especially in higher doses. Bacterial pathogens, we have to be cautious because, again, if we're slowing down that gastrointestinal tract motility, then we're increasing the contact time that feces or that fecal material has with the gastrointestinal mucosa. So if the animal has diarrhea because they have salmonella, then as we slow it down, that salmonella is actually going to have a greater chance at getting into the body and continuously affecting them. So we have to be careful because, again, we don't want to mask the symptoms of something really serious, and then we don't want to give it increased contact time as well. Sedation and stupor in animals that are lacking that P glycoprotein, such as collies, white feet, don't treat, then there is potential, especially in high doses, that we can see sedation or stupor because they were unable to break down some of the drugs and they got a higher dose technically than they should have. Moving on, we have anticholinergic drugs. Now, anticholinergic drugs, they block acetylcholine M1 receptors, and overall they decrease parasympathetic GI tract stimulation. So if it's an anticholinergic, what we're talking about is trying to stimulate that sympathetic nervous system response. Okay, so we often give anticholinergics. You'll see them used in anesthesia. If an animal's heart rate is low, if it's not ideal, then we'll give an anticholinergic to help bump that up and increase the effects of the sympathetic nervous system. So mode of action, they block acetylcholine M1 receptor. They decrease parasympathetic GI tract stimulation, so that's that motility and secretion. So this decreases segmental and peristaltic contractions. Watery feces can slide through quickly or cause ileus, either or. So side effects, parasympathetic blocking effects. So we've got to be very cautious with that because when we're blocking the parasympathetic nervous system, then the sympathetic will show through. So if it's an animal, of course, with cardiac issues, if we're giving them atropine to help with the diarrhea, then we're going to see an increase in heart rate, which is very uncomfortable for the animal in general and typically not ideal in any cardiac patient. Anticholinergics, we don't use very often at all for diarrhea. It's just important to note why we're giving them just in case. But because of their side effects on the parasympathetic nervous system, we typically don't use them at all in vet medicine. So again, if you see this in clinic, you can be comfortable in speaking with the doctor to ask questions about why they're using it because there are many other options out there, okay? So it's, again, advocating for the animals based on your knowledge. And then we have anti-inflammatory drugs. These reduce the secretions by blocking those prostaglandins. So remember that prostaglandins help increase the gastric secretions overall, or not secretions so much, but the gastrointestinal mucosal secretions and the motility. So we're blocking them by using anti-inflammatory drugs. But We have to remember that these prostaglandins are also protective. So we've got to be cautious with that because we might actually be blocking some of those protective agents. So essentially, sulfasalazine is an antibiotic with this salicylic molecule that we'll focus on. And then we have bismuth, which is essentially Pepto-Bismol. Both of these have salicylate as an antiprostaglandin. So it's the salicylate is the anti-inflammatory property in both of those drugs. Sulfasalazine is antibiotic of little use overall. And then so Pepto-Bismol, the bismuth coats the intestinal mucosa. So it's kind of interesting. They work on two different ways. We've got an antibiotic additive to the sulfasalazine, which doesn't really do much, but it also has that salicylate within it, that is the anti-inflammatory property. And then Pepto-Bismol has the salicylate, can't say that too fast, salicylate antiprostaglandin property for anti-inflammatory, but then it also works on a local or in a local way by coating the intestinal mucosa. So precautions with these, the number one is that owners will grab Pepto-Bismol all the time, for dogs, for cats, for everybody. But we have to keep in mind that Pepto-Bismol technically has the same ingredient as aspirin, and it's an anti-inflammatory. So you have to be cautious which animals are getting Pepto-Bismol. It's not a one-size-fits-all. It doesn't work for everybody. And of course, owners need to know that there is a degree of aspirin in Pepto-Bismol. So we have to watch the drug interactions as we start learning about anti-inflammatories. So the majority of the Pepto-Bismol coats the intestines, and then it's excreted with the bowel movement. During this coating effect, though, the salicylates are absorbed into the bloodstream. So looking at this again, when we talk about dogs, we don't want to overdo it and give them too much aspirin. But if we use it in cats, the salicylates are really toxic to cats. So in average human doses, they could be toxic to cats. So again, we have to be very cautious, and owners just plain old aren't aware that this is a side effect of Pepto-Bismol. Pepto-Bismol is also radio-opaque, so it interferes with radiographs, and it can affect evaluation overall. So if the animal does in fact have a foreign body in its gastrointestinal system, we might not be able to see that directly on the radiograph because of the presence of Pepto-Bismol. And then we have the sulfasalazine, which is a sulfa antibiotic, which we'll talk about later on. But it can have the side effect of keratoconjunctivitis sicca, which is essentially that continuous and chronic eye, dry eye, over and over again. So a couple of definite side effects that we have to be aware of. The main one here is Pepto-Bismol. I really worry. So many clients give Pepto-Bismol. Sometimes it can be recommended as a one-time dose by owners for their pets in emergency. And even with that, I would advise against its use in cats. So we have absorbents, which help absorb toxins. So they cause other molecules to adhere to their outer surfaces, so they are less likely to be absorbed into the body. They're often given inappropriately as cure-all agents. So if we look at, of course, we're talking about activated charcoal. So charcoal can cause other molecules to adhere, and then it can work its way through the body. So sometimes we use this as an anti-diarrheal. But of course, current day, activated charcoal is seen as a cure-all for everything in the human world, let alone in the animal world. So different examples of absorbents, we've got Pepto-Bismol, which could help absorb E. coli and enterotoxins. Doesn't have a huge effect on the animal. Kaolin pectate, many over-the-counter pet options are a lot of doctors will recommend kaolin pectate, or at least they did at one point. It's kind of like a clay-like substance. There's essentially a lack of clinical studies demonstrating absorption or decreased duration of diarrhea with kaolin pectate, so we tend not to recommend it so much anymore. And activated charcoal, for many toxin ingestions, it's beneficial because as it works its way down through the gastrointestinal tract, it will absorb some of those toxins and then take them out in the bowel movement. Typically, it's not generally used for diarrhea, but again, this is just introducing you to a couple things that you might come across in your practice, and you're allowed to ask questions about it. You know, like I learned that Pepto-Bismol is not the best for diarrhea in dogs and especially not cats. Why do you always recommend it? Ask questions. It's good to ask questions about this. This is why you're getting the knowledge. And then we have protectants, which coat the gastrointestinal tract wall to form a physical barrier to reduce contact with a toxin or an irritant or a disease-causing compound. In the upper GI tract, they work fairly well, but there's no evidence of benefit for lower GI tracts such as colitis, which of course causes the diarrhea most often. So protectants, again, we've got that multifunctional Pepto-Bismol. It has some coating ability of the intestinal tract, very small. Liquid barium, it's a radiograph contrast medium that acts as a protectant, and it may have some absorbent properties to it. It's often noted that GI patients after a barium series generally just feel better. So it's that kind of weird cure-all that we often give for one reason, and then it ends up having a secondary effect. Sucralfate reacts with hydrochloric acid to form a paste, and it exudates at the ulcer sites. It inactivates pepsin, which is that proteolytic enzyme from the stomach, and it binds bile acids. So it has some possible prostaglandin activity as well. We'll talk about sulcrate a bit later on, especially as well. So when we're talking about protectants, we have to have a little bit of precaution when using them. They can block drug absorption because they can bind to certain drugs. And we have to give separate from medications and food. Ideally, try to separate dosing by about 2 hours to minimize this effect overall. And that is it.